So, this intracoronary imaging and physiology is a very essential topic, and it's gaining momentum, and the use is being increased in US as well, as Bilal Bhai will share his experience over there. In Japan and other countries in Asia, it was being used much more frequently with PCIs, but as the data has come out and evidence has come out in favor of the imaging, especially, and with the iFR technology, the use has increased a lot in the US as well. So with that background in mind, in Pakistan, I think we lag behind in these new technologies because of cost issues, but we need to stay with the curve so that, and we need to find a solution as to how we can have access to these technologies to use them more frequently, because it does have impact on outcomes as well. So IVUS basic understanding and image interpretation. I'm going to start with the basics because we have a lot of fellows attending this talk as well. So when you start with CT angiography, you're talking about 230 to 600 micrometers of resolution, and with angiography it gets better. With IVUS it gets further better with 100 micrometers resolution, and OCT it's like high definition, very nice. So you can see a picture below how clear it keeps getting, the Mona Lisa picture with the imaging from CT angio to OCT. So what is IVUS? A catheter pulls back through a lesion or area of interest and results in series of tomographic cross-sectional images of the vessel. Sound waves are reflected or passed through structures depending on their density or acoustic impedance, and 60 images are produced in a 1 millimeter segment using a pullback speed of 5 millimeters per second. And what are the technologies available? We have two, Boston Scientific and Volcano, which is now taken over by Philips. So the Boston Scientific is a single transducer which rotates like the lighthouse effect on a drive shaft at 1800 RPMs. And the phased array solid state transducers is multiple 64 stationary transducers which emit the ultrasound waves. Now this is phased array. It does not have as high frequency as the rotational catheters. So Eagle Eye, which we have over here, this is 20 megahertz typically, and you can get on rotational catheters 40, 45, and with some of the other rotational catheters up to 60 megahertz frequency with resolution, a better resolution. And this is the OCT image with the even better resolution over here. So phased array versus rotational, if you were to buy, the rotational catheter is a better resolution, but there is blood speckle in the lumen, needs flushing before insertion. It is easier to cross. It's less bulkier than the phased array catheter, the rotational catheter. Resolution is better. But for CTO crossing, because it is closer to the tip, this phased array catheter, so that may be preferred only in that scenario. This is the Volcano catheter that I have in the lab. For the beginners, you just plug and play. It's very quick. You just plug it into this over here, and and you slide it over like a monorail system, like any balloon you would do. And this is the slide with which it is connected, which does a pullback. It's a very basic slide, which lets you do a pullback with this. So intracoronary ultrasound catheter is advanced down the coronary artery, and it's the ultrasound waves are perpendicular. It's coming perpendicular to the vessel like this, and you get cross-sectional images of the lumen. Why ultrasound? Why coronary angiography cannot explain by itself? Because you're looking at a straight picture of a three-dimensional structure. So it's a cross-sectional image over here of a lesion. If you look in RO view, it's a completely concentric lesion. It would look the same. But if it is an eccentric lesion like this, it would look fine in the RO view, but look very tight in the LO view, and you would never know what exactly the diameter of the lesion is, how tight it is. And in a complex lesion, look hazy in both the views, but look mild, and it may be tight with this complex lesion over here. There's another example. If you're looking at a lesion from here, it will just appear mild, 20% stenosis. If you're looking from here, 40%. You're looking from here, it looks like a 60% stenosis with eccentric like this. So that's why IVUS imaging can further elaborate the lesion. So when would you use IVUS? If you're using it before PCI, you would use it for left main significance. We'll elaborate further on all these points. You'd use it for culprit lesion in acute coronary syndrome. You can use it for angiographically ambiguous lesions, and you can use it to assess stent failure and also determine the risk of distal embolization. During PCI, you would need it for lesion preparation, CTO crossing, selecting the right landing zone, choosing balloon stent diameter length, evaluating the result after stenting, especially complex lesions like left main, bifurcation lesions, and calcifications, where all the data is coming out in favor that it has impact on hard outcomes as well by using IVUS and OCT in these settings. And with IVUS, you can reduce contrast volume as well. So basics of the grayscale, the more less dense the tissue, the more echolucent it is. So media appears, smooth muscles appear dark, and fatty tissue appears dark. As it gets fibrous and calcific, it appears more white, and adventitia appears more gray. So, and fibrofatty and fibrocalcific will be mixed over here in these shades of gray. So this is looking at a normal vessel with a catheter in here, and this is the border of the lumen. This is the intima here. This dark is the media, and outside of this is the adventitia over here. There's another example of that. This is the intima over here. This is the interface between the vessel lumen and the intima. This is the media over here, and adventitia behind it. And this is the coring guide wire behind which you're seeing the guide wire artifact. So if you're seeing the coring guide wire on the side, that is the Boston Scientific catheter, because with the phased array catheter, you don't see the guide wire in the lumen. So that's one advantage, I would say, of the phased array catheter there. So this is histopathology being correlated with the IVUS images. This is the intima, media, and adventitia. How does that correlate with IVUS? This is the media highlighted over there. Then this is the adventitia outside highlighted over here. And inside, this is the intima over here, which is plaque is dense with different shades of white or gray, depending on if it's lipid rich or it's fibrous or calcific. So this is on the